Hello, everyone. Good morning. It's very nice to see you all. So I would like to start our presentation about the pigmentation disorder subject. So skin covers all of our bodies, but its color varies from person to person. In order to see what gives the skin its color, we need to understand what are the four pigments. So these are the four main pigments of our skin. The first one is the oxidized hemoglobin, which are the red blood cells carrying the oxygen. This gives us the reddish color. We also have the non-oxidized hemoglobin, which gives us the blue color. So these are the red blood cells not carrying any oxygen. The third one is the carotenoids, which gives us the yellow pigment. And our guest of honor today is the melanin, which is brown. So why do we need melanin? Let's take a look at the outermost layer, the epidermis, and two important types of cells, the keratinocytes and melanocytes. The keratinocytes are the cells that form the surface of the skin and are the primary type of cell found in this layer. So this is the epidermis in this picture, and we can really see the keratinocytes all over it. And the second type is the melanocytes, which are star-shaped cells found in the bottom. So at the bottom of this picture, we can really see the basal layer, which is the lower layer of the epidermis, the base one, and in the middle, the melanocyte, which delivers the melanin, the pigment, to all of the keratinocytes. So in a normal state, there is one melanocyte that distributes melanin to every 36 keratinocytes. And in the basal layer, for 10 basal layer cells, there is one melanocyte. So this is the normal ratio. But in pigmentation disorders, like, for example, lentigo, we can see that the ratio changes to 1:4. So this is one example of disorder, and we will talk about it more, of course. And another point to mention is that the same ratio applies to all Fitzpatrick skin types, dark and fair. So this is also interesting. Let's zoom in more to the melanocyte. So in this picture, we can see the melanin production process. So if we start at the beginning of this process, we can see that when the UV rays contact the keratinocytes, which is the cell up at the top of this picture over here, the UV ray contacts it and starts a process with stages, a lot of stages actually, that at the end of the process, the melanin distributed to the keratinocytes. So first, the keratinocytes contact the melanocyte by a receptor over here, and then we can see a few stages on the way. And as I said, at the end, we can see these sphere-likes. These are the melanosomes that carry the pigment, the melanin, all the way back to the keratinocytes. So to answer my question, why do we need melanin, it's in order to protect the DNA, which inside the nucleus, because these melanosomes actually form a cup at the nucleus and protect the DNA from the rays to break it. I want to emphasize that we have both epidermal and dermal hyperpigmentation, or pigmentation disorder, if to be exact, because we have either a hypopigmentation or hyperpigmentation, and I will elaborate about it more. So it's very important to know where are we at? I mean, which case do I treat now? Is it epidermal or is it dermal? And of course, I will talk about it more, how to make difference between them both. So first, the causes, the reasons for these pigmentation disorders. It can be genetic. Of course, we know that every and each one of us have a different tendency to color and pigment, and of course, other things. Another thing is the medication use. So antibiotics or different medications can really cause pigmentation disorders, and I will also show interesting example later on. We also, of course, have the endocrinic reason, which mean hormonal changes. So the most common and familiar is pregnancy. During pregnancy, we can see cloasma or melasma if it's women that can use the pill, and you can really show a particular hyperpigmentation. I will also talk about it later. Another reason can be post-inflammatory or post-traumatic, which can be caused after acne, for example, or if the body, the skin is experiencing trauma. We can also see a defect at the pigment, at the melanin production. And the last reason in this subject can be also as a response to free radical damage. So let's dig in a little bit about the types of pigmentation disorders. So as I mentioned, it can be hypomelanosis, hyperpigmentation, or hypo. A little bit about hypo conditions that we have. Hypo means less. If hyper is more, then hypo is less. So albinos, for example, is a case of people who really don't have the melanin, I mean, absence of melanin, absence of the pigment. And these people usually will be very white, with white hair, white eyebrows, etc. The second one is vitiligo. Vitiligo is familiar with Michael Jackson, actually, and it's spots, or if to be more accurate, it's patches, white patches that you can see on the skin. So these bright or white patches really example and demonstrate the hypomelanosis, which means absence or deficiency in the melanin creation process. Another one is the PIH, which is post-inflammatory hypermelanosis. It can be hypo or either hyper. So for example, if we look at cases of post-acne, we can see that there are spots, there are stains of darker skin. So this can be post-inflammatory hyperpigmentation. And I will also show a case study about it at the end. So these are the hypomelanoses, and I also want to say that the albinos and the vitiligo types are the one that we unfortunately can't treat because these are permanent conditions and it's not for us to treat. But it's important if you meet a client with this kind of hypomelanosis to emphasize of the skin sensitivity and how important is it to keep the protection from the sun and every 2 hours. It's very important. I will explain about it more later, so stay tuned. The hypermelanosis types, as I said earlier, can be epidermal or dermal. So the epidermal one are brown spots that are called lentigo and are usually for brighter, fair skin types. So Fitzpatrick 1 to 3. And it's actually interesting because how do you explain if their skin is fair that there is more pigment, more melanin? Well, actually the reason is that the melanocyte density is changing, is raising. So if, like I said at the start, the normal state is 10 basal layers and so 1 melanocyte on every 10 basal layers, in this state, we will see 1 melanocyte for 4 basal layers. So the ratio is changing. It's not overflowing of melanin like in darker skin. It's different. We also have the freckles, which each melanocyte produces more melanin. And these freckles usually are a different type of melanin, which is pheomelanin. And actually, it's not something that we can treat. It's not the regular melanin, but this is this state. And the last one is the dermal one. So when I talk about the dermal, it means that it's usually something that had neglected, and this is a harder state, harder to treat because it's the melanin already sank into the dermis at the bottom of our skin at the second layer. So the spots will look very dark brown or even grayish blue. And this state usually will be with darker skin, which means Fitzpatrick 3 to 6, because 3 is in the middle. So 3 is like, can be either epidermal or dermal. Of course, there are exceptions, but usually the dermal one is for more higher Fitzpatrick skins. So if I sum it a little bit, the epidermal one will be, let's say, faster result when we treat correctly, because the melanin spots, the pigment is at the top of our skin. So it's easier to see the result. The time that will take is less than if the state is already dermal. If the melanin sank and in the dermis layer, there are no enzymes that can break it. So it will take a time. And this is the part where I want to emphasize that to clarify the expectations of the client. Because when a client comes and you ask, how long do you have the spots? And she says like 3 years. So it's important to emphasize that this won't be an easy process. Of course, if you will follow the rules, you will see the results, but you need to be consistent with the treatment. So, as I said, this is the way that you can see the lentigo, the solar lentigo one, the epidermal hyperpigmentation. It's usually, as I said, for fair Fitzpatrick, and it's not symmetrical. In these cases, you should know that underneath the spot, there is a skin damage or papillary damage that the spot covers to protect it. So if you will successfully remove the spot, you will see that the area will never be the same color of the skin. So it's also important for you to know this. And this dermal hyperpigmentation, which called melasma or cloasma, which is pregnancy melasma, it really looks different from the solar lentigo type. And you can see that it looks like coffee stains more, and it's symmetrical. So in the right picture, you can really see that it's in both sides of the upper lips. And if you'll have it usually on one side, you will also have it on the other side. So these are the characters of the melasma or cloasma. This is an also very interesting phenomena of hyperpigmentation while or after using minocycline, which is a type of antibiotics. So if you will meet a client with a pigmentation, like at the top, hyperpigmentation, like at the top picture, and maybe you'll think that it's a regular hyperpigmentation and you can treat it. And after a while, you will see that it's not working. Nothing is moving. Nothing, you can't see really any result. Then maybe you will think about asking of a medication history using of antibiotics or maybe even minocycline. And as you can see at the bottom, you can really see that the teeth also get this pigment. So actually, this is not melanin. This is an iron that sinks in the skin and also in the teeth. So for my proposal is for you, when you get a client, is first ask for a history of the medication use, and also ask nicely to see the teeth, because you really can spare a job and a future work, because this is unfortunately untreatable. So I wanted to let you know about this phenomena also. This is also an unfortunately case or cases. This called exogenous achronosis, which is an hyperpigmentation, but it's not treatable. And the reason for it is due to use of uncontrolled use of hydroquinone or resorcinol, phenol. So it's also a way for you to understand how important is the controlled treatment, and hydroquinone really needs breaks while using it, because you don't want to get to this point where it's already untreatable and it's actually not a nice condition to have or to see. Also, FYI. So let's talk a little bit about the ways of treating the pigmentation disorders. So first one will be pills. And why? Because we really want to get rid of the cells with the hypermelanosis. So the cells that contains the pigment needs to be shed. And how do we do it? By pills. We are trying to accelerate the turnover of the basal layer, and then the cells will shed faster. IPL is also an option. It's a technology of intense pulse light, which can remove the spots, but it's recommended to brighter Fitzpatricks. Also, an important element will be our active whitening or lightening products, which are melanin inhibitors, and I will, of course, elaborate it more. Products that support whitening are also very crucial, and also I will talk about it more. And of course, our sun protection products, which, as I mentioned at the beginning of the presentation, are the cause of the melanin creation. So when the rays of the sun hits the keratinocytes, it starts the process. So if we will not protect our skin from the sun, it will all go to waste. So let's dig in about the melanin inhibitors. Well, these are the active whitening ingredients that are used. The first one is the hydroquinone, which, as I said, has side effects when the use of it, while the use of it or after the use. So it needs to be used carefully. And usually by using it gradually. The other ones are azelaic acid, which is melanin inhibitor, and it inhibits the tyrosinase enzyme, and I will show it in a few seconds. Also, alpha-arbutin, which is, again, a tyrosinase inhibitor, and vitamin C stable derivatives, which are melanin inhibitors and antioxidant. They fight the free radicals. The last one will be oligopeptide 60H, which reduces the MITF levels. So let's look at this process again and understand what exactly are the stages that been inhibited by this melanin inhibitor. So over here at the bottom, you can really see the tyrosinase, TYR. This is the synthesis of tyrosine. So these three up here, the azelaic acid, the alpha-arbutin, and the vitamin C are all inhibited by inhibiting this point, this stage of the process. And as I mentioned, the oligopeptide 60H is reducing these MITF MITF levels. So each one of them is doing a different inhibition, and this is a very complex process. So this is why I'm mentioning all of this, because I want you to know that there are a lot of stages over here, and the recommendation is to use at least 3 different melanin inhibitor, since we can't really know which stage is malfunctioning. So if we look even more deep at the tyrosinase stage, we can really see that the vitamin C is inhibiting this one, which is turning the tyrosine to dopa, and the hydroquinone, the alpha-arbutin, and the azelaic acid is inhibiting this stage between the dopa to the dopaquinone production. The next one, as I said, is the lightening assistance. So this will be the support. They are not direct melanin inhibitors, but they contribute to the lightening mechanism. So these ones will be alpha hydroxyic acid, like lactic acid, which helps shed the layers, shed the upper and the cells more fast, so we can really get rid of the hyperpigmentation, and retinoids that help regulate the mitosis of melanocytes. Also supporting are the antioxidants and the anti-inflammatory agents. Antioxidants are fighting free radicals. They also stop photoaging. They are anti-cancer agents. And of course, they are reducing or inhibiting the melanin by reducing the melanocyte stress. In this picture, we can really see with our eyes what is the difference that the antioxidant can make. So at the right one, it's a picture with no antioxidant added. And at the left one, we can really see that the melanocyte is brighter. So the antioxidant actually brighter, lighter our skin. Sun protection is very, very important here. It's crucial. So a few things about these rays. These are the main characters at this table. So UVA can go through glass and it can cause photoaging and skin cancer. UVB rays does not go through glass, but they can really cause erythema and skin burns. And we also have the infrared rays, which are heat radiation, and they can cause the melanocyte to be hyperactivity. I also want to emphasize that the SPF, which is sun protection factor, is describing the duration of protection from UVB, but it's not indicating of the protection from UVA rays that are similar to all sun protectors, which is 2 hours. And this is the reason why it's very crucial to renew our sun protection every 2 hours. Also important for me to emphasize that the UVA and the UVB exist all year, and we really need to pay attention and protect our skin with applying sunscreens every 2 hours. It really can't be taken for granted. So in summary, all the important things I want you to remember, we can really count on 4 fingers. So these are the 4 elements. The first one, as I said a lot, is the sun protection every 2 hours. The second one will be melanin inhibitors, because we really want to inhibit the pigment, the over pigment that we have in order to solve the hyperpigmentation disorder. The third one will be the keratolytic agents. So these are the ones that help shed the cells in clinic, of course, and at home. And last but not least, the supporting care, antioxidant and anti-inflammatory agents. This is also a really nice sum up for this presentation. So this is really the process from the beginning to the end, and we can really see that all of these can help us solve the issue by contacting different stations. So at first, the sun, as we said, this is the cause for all of this. So the sun protection is crucial over here. The second is the anti-inflammatory agents and the antioxidants that contact in this stage of the process between the keratinocyte to the melanocyte. Lactic acid and retinoids that can help reducing the manufacturing over here. Oligopeptide 68, which is a melanin inhibitor to the MITF, which I showed you, and the other melanin inhibitors, which are hydroquinone, alpha-arbutin, azelaic acid, and vitamin C with 10%, at least 10% of stable derivatives. So all of these are helping inhibiting the melanin synthesis. So let's take a look a little bit about a program of treating. So this can help us understand how do we treat step by step. So at home, we will use 10 to 15 lactic acid. So it can be the lacto-10 or hydrogel or the lacto-15 ceramide. Of course, the melanin inhibitors, which I will soon show the products, retinoids, antioxidants, and again, sun protection. And in clinic, we will do a yearly series of 6 to 10 pills, one every 2 weeks. And following this series, a pill every 4 to 6 weeks for maintenance. Also, we can add the IPL technology. And next one will be the program for the darker skin, for the 4 to 6 Fitzpatrick. It's pretty the same, but it's important for me to emphasize the differences. So in clinic, we will really need a preparation for melanin inhibitors and alpha-hydroxyic acid, which are lactic acids, 3 weeks prior to the pills. So this is also an important stage when you treat hyperpigmentation of darker skin. And the second difference is the IPL, which is not recommended in this darker skin. This is a table that really sums our products and the activity of lightening, the exact activity, which I talked about, but I think it's a nice table to have and to look at sometimes to really understand what exactly are the products doing. So our first and most common product is the double white. So we have 2 pumps in this product. The A1 will be vitamin C with derivatives, stable derivatives of ascorbyl glucoside and ascorbyl tetraisopalmitate. And they are, as I mentioned, fighting free radicals plus melanin inhibitors. The B pump will be azelaic acid, 20% of it, plus 5% of alpha-arbutin. So if we look at the B pump separately, it's really melanin inhibitor because we have two in here, but the azelaic acid is also keratolytic, has a keratolytic character. So it can also help with the turnover, as I mentioned, that we need to do in order to shed the color, the pigment. And also more recent review claimed that 20% azelaic acid is being more potent than 4% hydroquinone without adverse event, without side effects. So it's also nice to know that this is a really effective melanin inhibitor. The cousin, if we can call it like this, of the double white is the double fight. So the B pump is the same one, the azelaic 20% plus 5% of alpha arbutin, and the A pump will be our hydrogel, which is 10% lactic acid plus 2% of salicylic acid. The double fight is actually for treating acne. But as I mentioned at the beginning, there is a possibility of PIH, which is post-inflammatory hyperpigmentation, because the spots of the post-acne are usually caused by not protecting while using and treating acne. So we can really try and treat and even prevent these post-acne spots by using the double fight, and thanks to the azelaic acid. Also, of course, we have our very special product of azelaic forte, which is 25 azelaic acid plus 5% of alpha-arbutin. And our vitamin C serum, again, 11% percentage of stable derivatives, the ascorbyl tetraisopalmitate and the ascorbyl glucoside, which is actually the same product like the A pump at the double white. Retinol, of course, the retinol charisma has special ingredients, active ingredients in it, except to the retinol itself, which are the lantopodium extract that is fighting free radicals and supporting the retinol for stabilizing it. The oligopeptide 68, which is the melanin inhibitor that we talked about, and the perfluorocarbon emulsion, which helps us kill the acne bacteria, since the acne is anaerobic. So if we give it oxygen, and that's exactly what this ingredient does, it just releases oxygens. So it can really fight acne, but it can also help us with anti-age because it's helping reducing the stress. So we can see that the retinol charisma is really an ace. It can help us treat a few different conditions because it has the melanin inhibitor in it and the anti-aging free radicals ingredients, and of course the retinol itself. I also want to mention that the product is available in 3 concentrations. So the delicate one is 0.3%. The intensive one is 1%, and the plus and the stronger one is 1.6%. Another nice addition that can use as a boost for treating hyperpigmentation is our ampoules. So first we have the lift and whitening complex, which contains the oligopeptide 68, which, as I talked a lot about, the melanin inhibitor, and the peptide of matrixyl, which is actually called mesoperation without needles, since it can really do the same as mesoperation technology is doing. It's helping the fibroblasts that are creating the elastin to create more. So that means really a lift and a short story. So this is the name, this is the origin of the name, lift and whitening. It can really help us with this hyperpigmentation plus treating different states. And the acne complex, which are for me the most surprising, because usually we use the acne for acne cases. But thanks to the niacinamide that we have in here, that actually inhibits the melanosomes that I showed you that contains the pigment and bring them, distribute the pigment back to the keratinocytes. So the niacinamide is inhibiting them. This is this is in high concentration, it's 6% of it, and can really help us with inhibiting and helping with hyperpigmentation disorders. Plus, we also have the ingredients that can help us soothe the skin and anti-inflammatory agents, which are the arnica extract, 10% of it, and the potassium glycerizate, also oligopeptide 10. All of these can really help us. So in this product, we really have two elements of the fourth that I've talked about. Melanin inhibitor plus anti-inflammatory. Of course, this is a boost. It's not a standalone, but it's a really nice and helpful addition. And of course, the sun protectors. So our first one is the multivite, which contains the encapsulated UV pearls, the titanium dioxide, and the vitamins. So C, E, and B, which is niacinamide. So this is a really, we can call it a whole product, because it's not only sun protector, it can only help with soothing the skin thanks to the vitamins, and the vitamin B, the niacinamide, which is also helping with inhibiting the melanin. And of course, the queen, the brush, mineral powder, brush and go, that can really help us renew our sun protection every 2 hours. Like I mentioned, it's very, very crucial. And it's also not sensitive to heat, so you can really keep it in your car or everywhere you want. For me, it's really the queen. So if I would like to sum it all up in 3 sentences, the successful treatment will be knowing and understanding these 3 main issues. So we need to understand the location of melanin accumulation. So if it's epidermal or dermal, and we know it by the time that the stains are existing, and by the history of medication, of course, by the Fitzpatrick type. So this can help us treat the correct and right way. Also the different types of pigmentation disorders, which of course are important. If it's lentigo or if it's melasma, we will treat it differently. And the different ways to treat the pigmentation disorders. Well, this is the before and after of a woman that actually has a few conditions of hyperpigmentations all together. So when she was young, she had acne. So she has an history of using isotretinoin, which also known as Accutane. So this is a strong ingredient, a strong medicine. And since she didn't protect her skin and didn't use the sun protections every 2 hours, we can really see in this case the post-inflammatory hyperpigmentation, which I talked about, plus lentigo spots and melasma. So this is a very complex case, and the use at home of the home cares products was Azelaic Forte 25, retinol charisma, plus Lacto-10, vitamin C serum, the lift and whitening peptide ampoules, Iglomist, plus our sun protectors, which are the Multivite and the Brush and Go. And in clinic, of course, as I mentioned, we can't skip it. She was treated by peel and protocol of our in clinic for 1 in every 2 and every 3 weeks. And the result was seen after 15 weeks. And in this picture, the lower one, the bottom picture, we can really see the results after 5 months. So I think that this is a good sum up for my presentation, since we can really see that the melasma spots, the melasma type of hyperpigmentation, which we can see at the top of the lip, didn't really fade away. So it's brighter, it's lighter if we compare it to the before picture, but it didn't went totally. So if we look at the other spots like the lentigo over here, we can really see that are brighter than the melasma. So this is for conclusion, how important is the expectation meeting with the client, since some of the spots can be brighter with less time, and some of them, which are already dermal, can take a longer time. That's it. Thank you.